Good day. This is my submission for the fetal assessment module for the Master's Program 2014. My topic in the Controversies in Obstetrics assignment is we should replace our conventional intrapartum CTG monitoring with ST analysis of the fetal electrocardiogram. The rationale for monitoring fetal heart rate is that fetal heart rate patterns are indirect markers of the fetal cardiac and medullary responses to blood changes, acidemia, hypoxia, since the brain modulates heart rate. And virtually all organizations advise monitoring of the fetal heart rate in labor. So the aim of fetal monitoring is to identify fetuses at risk of an adverse outcome, long-term hypoxic ischemic injury, based on our interpretive ability to understand what is happening and how the fetus capably reacts to stress before it becomes a risk situation. Despite developments, the need still remains to improve fetal outcome, and standard CTG has a high specificity for classification of normality and severe pathological traces. This is problems later. The combination of ST analysis and standard CTG parameters, however, provides more accurate information about the fetus during labor than CTG does alone. Right, now approximately 300,000 pregnant women have CTG monitoring annually. It has a low sensitivity but a very high specificity, i.e. while a normal trace is reassuring that the fetus is well and a normal trace is not necessarily indicative of hypoxia. In one study, 0.19% of children with intrapartum CTG showing late decelebrations and reduced variability had moderate to severe CP. That's a false positive rate of 99.8%. Now, for the obstetrician itself, this is the crux of our career woes, litigation, personal guilt, etc. For the child, obviously, we have neonatal outcomes and the worst case scenario, death. So a comparative analysis of what's happening. The CTG itself has a few inclusion criteria which need to be fulfilled for it to start. Fetal, intrapartum, and maternal risk factors as well. Maternal disease, previous sections, abnormal fetal presentation, reduced movements, augmentation using oxytocin, pain during labor that's separate from contractions, maternal pyrexia, passage of meconium, and so on. So and on the left side are all the criteria on how CTG is assessed, with contractions with a heart rate, reassuring and reassuring, variability from beat to beat, acceleration, and then there's an overall impression of the CTG, and that's what we use to interpret it. This is the current gold standard. What we're discussing here today is the ST analysis of the fetal electrocardiogram. Same inclusion criteria as the CTG. This is not recommended for first use in the second stage of labor, so meaning this must be started prior to labor begins. And the usual contraindications to invasive fetal monitoring preclude the use of STAN. So this can start when there is certainty that the fetus is not already hypoxic. So normal variability, and CTG with a steady baseline activity, and if it's suspicious, we need to do an FPS. So on the most right-hand side is the guidelines and the management protocols. So what is involved? An electrode is directly attached, and then we obtain a higher quality signal because this is through the perineum prior to the fetal scalp, attached to a computer then for signal processing. Hypoxemia will alter the PR and RR intervals. This has no statistical significance, and what we're looking at is the ST analysis of elevation or depression. And performing an ECG without a CTG has never been trialed. And this is what it looks like for the maternal and the fetus. And that's all the placement locations of the electrode. So the future. As per the Cochrane review of 6 RCTs and 16,295 women, this is a more reliable indicator of fetal well-being than CTG alone. Unequivocally, though, there was no difference in number of C-sections and perinatal mortality. There was less fetal blood sampling and instrumental deliveries, however. This concludes that there is modest support for STAN. However, considers the disadvantages of needing a fetal scalp electrode. The waters need to be broken first before the scalp can be placed on the electrode. Yes. And there are ethical issues as well. The lead author of all RCTs by one that previously strongly supported the use of ST analysis for fetal ECG monitoring is the head of the company that's solely producing the STAN technology. previous meta-analysis of the 5 RCTs had strongly advocated stand to replace the CTG, giving rates of 42% reduction in C-sections, 52% reductions in FPS, 69% reduction in metabolic acidosis. But then the breach controversy arises because the exclusion criteria in these RCTs, which strongly advocate stand, fail to mention that breach presentation is one of the exclusion criteria. But this is an important inclusion criteria for continuous fetal monitoring with the CTG. So, 2014 evidence that takes this into account and corrects for that error, evidence not so robust, and it makes the above trials negligible, giving the conclusion I mentioned above. And STAN as well is not part of the RCOG training curriculum, so trainees may rotate to units where they're expected to use the SCG, fetal ECG, without knowing how to use it, without having been properly trained. Now, practical cost analysis and advantage benefit ratios. So we know that the fetal ECGs are contaminated by fetal brain activity, for one thing, fetal and maternal movements, muscle movements, artifacts, and all the different layers of muscle tissue fat, the vernix caseosum of the baby through which these electrical signals must pass. Using the fetal ECG method does, however, aid in reducing the human factor, which clouds sole CTG interpretation as our second source of information as to fetal well-being. In our setting of limited resources, implementing the fetal ECG monitors instead of the CTG involves a lot of time, a lot of expense, and specific training of midwives and obstetricians who will then interpret these results. It's very unlikely to take off in standalone midwifery units or where you need one-to-one care. And you must remember that this is a complete loss of mobility then for the mother. She is just going to lie supine and she cannot move because of all the electrodes. The number needed to harm as well is not very significant. Number needed to harm to prevent one case of metabolic acidosis is 250. CTG alone 661 would be the number needed to harm, and a number needed to harm 628 to prevent one case of neonatal seizures. In summation, since the introduction of continuous fetal monitoring since the 70s, no one technique has lived up to the promise of reducing perinatal mortality and injury. The largest multi-center trial, but in the US, is still ongoing. To completely replace the CTG would be dangerous. In-depth interpretative skill, like the K2 training for CTGs, is a basic necessity. It should be an independent tool acting to validate or invalidate a hypothesis. But not as a sole tool. It has to be an adjunct. And it is not, and as it stands from January 2015, RCOG advocates that best practice recommendations are to use the fetal ECG as an adjunct to the CT during labor, but not routinely. It's currently not recommended as standard by NICE guidelines, and it is being used together with the CTG in some UK units with evidence that it reduces the number of perinatal injury and instrumentation. More time is obviously required to look at the long-term outcomes. As intrapartum fetal surveillance has evolved over time from the wooden Linick Pinard stethoscope to the CTG, moving forward that involves taking on board the latest in evidence-based improvements. So we take on board modest support for the STAN, and putting maternal and fetal well-being first means that we use the ST analysis of the fetal ECG when indicated in conjunct with the CTG instead of replacing it. That is the end of the presentation. Thank you very much for listening to me rattle on.